So yeah, so whenever you're ready, really.
Okay. Good evening to everybody. I am Cosimo Pieri from Europa Uomo Europe, and Tania Estapé is also from Europa Uomo Europe and will join me soon. Our objective today is to introduce and give some answer about a specific tool, which is, let's say, one of probably one of the first which I saw, which is aimed to connect, is able to help people to connect to the multiple data that are available in the world. So it's creating a sort of link between what is the situation of the single patient and his doctor in the decision stage with the entire experience in the world past experience. Our association, as you know, all support early diagnosis and multidisciplinary approach, and this is our main item of activity. And as you probably know, we did already in 2020, 2021, many webinars about active surveillance in particular, presenting new developments. We were giving possibility to listen to many important urologists and specialists all around the world, more than 10. And we had also a similar number of patients which were testimonial of the situation, which gave us some view of what is happening in the world, both in the area of the knowledge, the medical knowledge, and both in the area of the real patient situation. With this, why did this with this for the seminar? As I said before, the idea is to improve the effectiveness of decision-making process. One of the things that we all saw personally as patients, and also as let's say as persons in the association, is the critical moment. One of the critical moment of all the activity is just after the diagnosis, when the patient and his doctors and the specialists have to decide about the treatment and to decide what to do. So in this specific situation, more information and more support is given to the patient, the best it is. So now we wanted to present this tool as one of the support tools that could be to the customer. We know that to the patient. We know that it's very complex, the decision making in after a diagnosis, because every patient has a different situation, every doctor has a different experience. There could be other comorbidity for the patient. So it's a very, and over that, most of the time, the patient received a diagnosis of a cancer, and which is certainly very heavy in his psychological attitude. So what we wanted to say today is that the tool is not the main element of the support. Certainly the medical structure and the patient have many information, but what we think is what we thought useful to present the tool, because we think that it is another support, and we will see in the future how much this is used, will be used, if they will be used, when it will be used, but certainly we think that it could be a support element. So now to do this, we have invited Vincent Gnanapragasam. It's not easy to pronounce his name. He just told me he's from Malaysia, and because from Cambridge University, they working in this area, they have developed a tool which is already used in many areas, in countries also. So we are curious to understand this and see, and this will be an help for the future decision when or where we could see this in use. So now, Vincent, I hope you are online.
Yes, thanks,
Okay,
Cosimo.
how are you today?
Very well, thank you. Very kind of you and Tanya to invite me to speak, and to all of you to attend today.
I hope you agree with my presentation. We are very
Absolutely.
curious. We are very curious, and we think that interesting to have your. So I leave you the stage.
Thank you, Cosimo. Very kind of you, and again, thank you for the opportunity. The reason I am here today is that I was at the EAU meeting recently, and I was very struck by the presentations that Europa Uomo had done on patient survivorship, which I think Tanya was presenting. And we developed Predict Prostate some time ago, a few years ago, and I'm very keen to disseminate it for patients to use and benefit. It's already used very much in the UK, and it is available for anywhere to be used, which I'll show in a little while. But I really wanted to engage with your organization because I think you are the absolute best group to look at this, and I hope we'll be willing to support disseminating it. So I will try not to go on for too long today, but what I'd like to do today is to talk a little bit about how clinicians do risk assessment in terms of new prostate cancer. I apologize, as many of you may already know a lot about this, but let me just give you some history and some background on how risk and particularly prognosis has come about and how it is used in clinical management, particularly when we talk about active surveillance, which is really the focus of the group today, and where we think Predict Prostate is particularly useful. So I think the first thing you will all know from many headlines in your own countries that prostate cancer seems to have two heads. And sometimes the prostate cancer message we get in the news suggests that actually you don't need to treat many prostate cancers, and treatment may be actually over-aggressive. And certainly in the UK, we had this happen in 2016 when the PROTECT study, which is a large randomized study of treatment versus non-treatment, came out, because actually there was no difference in survival between the treatment and non-treatment groups. But then a very short time later, there were other headlines which came out which suggested that prostate cancer actually causes many, many deaths. And that started a spike of early detection and testing and a greater emphasis on treatment. So of course, it is a bit odd that you can have the same disease having very different focuses. And of course, the truth is that there are very different types of prostate cancer. And the question of what you treat and how you treat is very much dependent on understanding the nature of it. Now, historically, how the clinicians and urologists have classified prostate cancer is if you're diagnosed with prostate cancer, they look at your biopsy grade, they look at your PSA, they look at what a scan or clinical examination may show. And traditionally, they used to put people into three groups: low risk, intermediate, and high risk. And many of you may have heard of this in your own diagnosis if you have prostate cancer. There have been many modifications of this over the years, but up till 2022, the EAU as an organization still uses old-fashioned three-tier risk stratification system. In America, they developed other things called the CAPRA score, which is a point system, and more recently a 10-point system. But all of these were basically used to counsel men as to whether they should have treatment or not. The most important thing to recognize is many of these tools were not developed thinking about other morbidities. And also, risk actually refers to the risk of treatment relapse, not survival. And that is one of the problems with the current models. So up till about 2016 or 17, we were putting men into these three baskets, and that was what the guidelines then would recommend for in each man about what treatment options they may have. Now, very briefly, in the UK, we have changed this because we reworked and looked at what are the factors that result in risk, and we found that if you divide men into 5 groups, you got a much more powerful way of predicting whether they were likely to die of prostate cancer compared to the 3 risk tier system. So the Cambridge prognostic groups is the new criteria which is used in the UK, and the National Institute for Health and Care Excellence, which is our group, our organization, which tells us how to practice and what to practice, has recommended the 5-tier system. Now, here on this page, you don't have to read it, but what I will tell you is that the NICE organization actually recommends whether you can have surveillance or treatment depending on which of the CPG groups you're in. And if you're in CPG1, which is very similar to the old low risk, surveillance is considered to be the top treatment that you would recommend, or management you'd be recommended. But you can choose to have treatment with surgery or radiotherapy if you wish. If you have CPG2, which is the next level up, then you can still have any of those options. But when you get up to CPG3 and above, surveillance becomes much less recommended option and really not really a top line of, treatment option. So in fact, in counseling in the UK for people who use this, and I'm afraid not everyone does, pretty much if you've got CPG1 or CPG2, surveillance is what you'll be counseled to have. And that is guidelines from our national body. So we have made progress in the UK. We now use 5 baskets instead of 3. So it's better, but it's certainly not perfect. And this is important because, as you will all know, all of us sitting here, that really we are not dealing with a prostate cancer which comes to the office or the clinic on its legs. It comes within a man, and that man has a complex life. That life has many other facets which have to be considered when you're trying to decide on treatment, because quality of life is just as important as survival. This is a gentleman called Harvey Cushing who actually lived in the previous century, and he was actually a surgeon. But he was one of the first to say that we have to consider not just the organ, in this case the prostate, but the whole man, and not just the whole man, but the world he lives in as well. What are his other issues? And I think this is really important with prostate cancer for the very simple reason that actually the chance of dying of prostate cancer, even when diagnosed, is actually almost always less than the chance of dying of something else. Now, this is data from Sweden. I don't know if there's anyone from Sweden here, published now nearly 9 years ago. And in Sweden, they have a fantastic database called the PC-based dataset. And there, they were able to look at men who actually never had any treatment for their prostate cancer and follow them over 15 years. This is a very large dataset, hundreds of thousands of men. Now, in short, in this graph here, in this table, if you look at the groups where the green and the blue, which is basically the risk of dying of cardiovascular or heart problems or other causes, versus the orange, which is dying of prostate cancer, you will see that actually you have to have the high risk type of prostate cancer and be young in the other groups. And that's the only time that prostate cancer mortality risk is actually the same as other causes. So this is important data for us because actually if you happen to be in any of the other categories, and particularly as you get older, your chance of dying of something else is so much greater that you have to be really clear on what you're going to gain from treating that prostate cancer. So the other aspect, of course, is that treatments come with side effects. This is another paper which is really again from 9 years ago. So and they did their work over 15 years. So we've known a lot of this for a long time. These graphs here show what happens to urinary function, sexual function, and bowel function after either surgery or radiotherapy. And you can see here that there is a decrease in functional quality, which actually maintains for up to 15 years after treatment. So giving a treatment has consequences for a man's quality of life for many, many years after the treatment. So we have to be careful, as far, in my opinion, as clinicians, when we start to recommend treatments that we know it's going to give benefit. This is also a similar sort of thing, and this time from the Protect data from the UK. And very importantly, they also had a group of men who had surveillance or monitoring. And here you can see that if you compare, so monitoring is in green, surgery is in red, radiotherapy is in blue, and black is brachytherapy or radioactive seeds. And the higher the score, the worse the functional problems that these men are having. Again, you see the situation where really, if you have surgery, for example, you have much worse continence problems, leaking of urine, things like this, compared to if you have nothing or surveillance. And that problem persists for even up to 6 years after treatment. Loss of erections, a major problem for anyone who's having treatment, and it remains a big problem, much higher rate than the surveillance men, again, for up to 6 years. And of course, the other thing that happens is that with age, there is a natural loss of some of these functions. So it's not to say that, if you have surveillance, you'll stay as you are, because we are all aging, and that obviously is a factor. But there's no doubt that in the interval period, if you have treatment, you're going to have much more problems in terms of continence, functional outcomes, erections, things like this. So with all these ideas in mind, we were very keen to see how you could actually start to work a balance between the risk that the prostate cancer would convey to an individual as opposed to the risk of them dying of something else. And also, in some way, think about the side effects. And we built the Predict Prostate model. Predict Prostate was first published in 2019 in this paper using UK datasets, but as I will show you, it's since been tested and validated in many other cohorts. And it balances the value of treatment against prostate cancer mortality, so risk of dying of prostate cancer, and versus other mortality. The website is freely accessible and has been and has had over 60,000 hits over the last 3 years. So I have some questions which Cosimo sent me. One of them was, what is the new information that Predict Prostate offers for critical decision making? So I would invite all of you to try the website out, and I think Cosimo has this already. So what Predict does is it takes information about your age, your PSA, the stage of your cancer. It looks at your comorbidity, your other illnesses by looking at hospital admissions. We also have BRCA there. So if you have a family history of the BRCA mutation, you can put this in. It is a tool only for non-metastatic prostate cancer. You put in your information about your biopsies and what kind of cancer it was, how many cancer cores were positive, this sort of thing. And the model will generate, first of all, the estimated chance of dying of prostate cancer versus dying of other causes, which you can then look over a 10 or 15-year period. Then you can select between either going on surveillance or conservative treatment versus treatment with something like surgery or radiotherapy, and it will tell you what your estimated chance of dying is reduced by having that treatment. So in this particular case, for this gentleman of 65 with a low PSA of 5, he actually had a grade group 3 prostate cancer, but only less than half the samples were positive. His survival gain from having treatment is 7% over a 15-year horizon. In that time, about 26 men will die of something else because he is 65, and about 60 men will be alive. So this gives you a context to say what the likely survival benefit is from treatment. And of course, if you have lower grades, typical of surveillance or lower PSAs and things, the actual survival benefit is much less. There are different displays, which depending on how you would like to view things, you can use. So you can have these survival curves here or stacked charts, or indeed you can have the data shown to you in text form. And all of these displays have been designed in consultation with patient groups to see what information or what way the information is conveyed works best for them. So another question which came was, what is the typical situation in which you might use Predict Prostate, and how does it help? And how does it balance the value of treatment against other factors? So I've already explained some of that already. So let's take an example which is typical for surveillance. This is a 61-year-old man who's got few other illnesses. His PSA is 6, his MRI scan is a T2, which organ confined, and the biopsies are grade group 1 or Gleason 6 in one of 13 samples. So we can put his details in like I showed you before. So in this chap's case, if you look at conservative, which is surveillance option, then, and over 15 years, you will see that the chance of dying of prostate cancer is about 4 out of 100. But the chance of dying of something else is 17, so 4 times higher risk of dying of something else. And actually, the majority of men, about 79, will actually be alive. Now, if you had treatment, then the treatment would save 2 lives just by probability. So there is still about a 2% risk of dying of prostate cancer, just like with anything, but treatment would give you a 2% survival benefit. But of course, the risk of actually dying of something else still remains, and the chance of actually being alive with nothing happening also still remains. So in this chap's case, if I was seeing him in clinic, I would counsel him that treatment would give him a 2% added survival benefit versus a 17% risk of other cause mortality. And this kind of data is very helpful for an individual man to sort of work out whether it's worth thinking about going for treatment or not. And the other thing Predict does, and this is not tailored to the individual, but it's based on the latest trial data, it actually puts side by side the various treatment options. And as I already showed you earlier on, the risk of actually developing things like erection problems or incontinence or bowel problems now this is 3 years, but we now have 6 years data on the website, so that they can actually see what the impact from treatment might be on quality of life as well. Now, it's all very well to do these things, but the question is how and what impact does it have? Now, the most important factor here for any man who's diagnosed with prostate cancer is how they interact with and who they speak to about their prostate cancer. And I'll be very honest with you and say that I'm very disappointed in the relatively low levels of awareness and knowledge amongst clinicians when it comes to this. There are some very good at it, but not many. And the reason I know this is that we did do a study which we published. And what we did was we sent to about 160 or 180 clinicians who see men regularly to counsel for prostate cancer. And we asked them to tell us what they thought was the estimated risk of dying of prostate cancer for 10 or 12 typical cases that we sent them. So they then gave us an estimate of the likelihood of dying of prostate cancer. And we compared that against the Predict Prostate estimate. The next thing we did was we actually sent them similar cases, but this time we showed them the Predict Prostate calculated estimate. And the data was really quite striking. In this table here, the green bars represents the range of opinions for all these clinicians for a one typical case. And you can see that it varied greatly. So what they were saying, the risk of dying of prostate cancer ranged from 40% to 80% just across the clinicians without using Predict. The actual Predict estimate was 18%. And nearly with all the cases we found this, there was very little consistency on what they thought the risk of prostate cancer death was, and not very often were they actually within the range of the Predict Prostate estimated model. Now, the other thing that happened is when we showed them the cases with Predict, the likelihood that they would recommend radical treatment for a given individual was reduced in 6 out of 10 cases. So a 60% reduction in the likelihood of recommending treatment once they saw the Predict estimates. So this is the clinicians, this is the doctors who are seeing patients regularly. We were able to show that the tool or use of the tool really made a material difference in how they counsel the patients. And then the next thing we did was to ask what happens with patients. So to do this, and it's quite a difficult thing to do this kind of study, we did a randomized study in the UK among 8 centers, and for men newly diagnosed with prostate cancer, particularly those where they were trying to make a decision about what to do. Now, our aim wasn't to see whether Predict actually changed their treatment decision, but to ask whether it improved their understanding of their prostate cancer characteristics. And again, much like the other study, we found that when patients saw the Predict Prostate tool compared to patients who didn't, their overall decisional conflict, meaning to say their uncertainty, their worries about it, their anxiety about making a decision whether they were right or wrong, was reduced quite significantly. And we found that overall it reduced uncertainty. It actually made their perceptions about the risk of being treated, the risk of treatment benefit much more realistic. And we found that it was highly valued by the patients, and the patients actually would recommend it to a friend or colleague who was also similarly diagnosed. So these studies are very important when you're talking about decision or risk communication tools, which is what Predict is. Because if it doesn't actually make a difference when it comes to clinical practice or patient utility, then there's not much point using it. So at the moment, the way we like to see it is that Predict allows a man to be in his own basket, not in 3 baskets or 5 baskets, but actually have information which is tailored as much as we can for that individual. Of course, there are many other factors that have to be considered, as Cosimo mentioned. So this is a risk communication tool, if you like, to be the baseline on which decisions are made. And then coming to some other things about Predict Prostate, because obviously, it's all very well me who developed it telling you about it. The question is, how good is it and what is the evidence that it's good? So what information was used to develop and how reliable and robust is the estimates? So we have now published a number of papers on Predict, apart from that first paper. We've actually done studies in a Swedish cohort, in a Singapore cohort, in an American cohort, as well as the UK cohort. In fact, more than 350,000 men's data and details have been plugged into the model from 4 different countries and multiple ethnicities, may I say as well. And consistently, the performance of the model has always been in the region of about 80 to 85% accurate. It's actually the most validated tool there is if you look at all the papers published on the other things which people use in America or even in the UK. In fact, the EAU risk classification system has never actually been validated or tested in this way before. So we are pretty confident that the tool is robust. And these are all peer-reviewed papers published in major journals. Predict was reviewed by the National Institute for Health and Care Excellence in the UK, as I mentioned, and they actually have endorsed it, which means that they have actually supported its use for clinical decision making and risk assessment. And it's the only decision making tool which is endorsed by NICE for prostate cancer. To date, the tool, like I said, has been accessed more than 60,000 times in the last 2 years. We get accesses from over 100 countries regularly, and every month about 3,000 users. So it is being used very robustly, and we are very keen now to expand that and to raise awareness, actually, that this tool is available and out there to men from many countries, to at least know it's there to get information which is not purely coming from just one source. So another question is, what are the limits of the application and what times is not suitable? So that's a very good question. And to be absolutely clear, this tool and the website, the whole thing is based on men where you could actually choose between having surveillance or treatment. So if you've got aggressive prostate cancer, high grade, for example, or locally advanced, has gone out of the prostate or metastatic cancer, then this is not a tool for you. Because of course, in that situation, it is never the case that you will not treat someone. What we have done is compared the outcomes between surveillance or monitoring versus treatment. And you don't have that kind of data for very high grade, high stage cancer. So it's not suitable for men like that. Certainly not suitable for men who've already had some treatment for prostate cancer or have any other features which are abnormal, things which might suggest the cancer will behave differently from standard cancers. So those men, this is not suitable for. But it is very suitable for active surveillance. So let me turn my attention now to active surveillance. As you know, the critical decision make point in active surveillance is always, is it the right thing to do? What is the risk if I don't have treatment now? And how do I know that I've made the right decision? That is always the key things that men who are going on active surveillance find very difficult. So we have incorporated both the Cambridge prognostic groups I told you about and Predict Prostate into our decision making in Cambridge. And how do we use it? Well, if we start with at the top, which is where you get a man being investigated for prostate cancer, and let's say they are diagnosed. So then they come to a multidisciplinary meeting and we look at their grade, their stage, their PSA, their other illnesses, and we can categorize their cancers by the CPG model first of all. And then I often see many of these men for decision making, and I will calculate for them the Predict Prostate estimate of survival benefit from treatment if they are suitable for either surveillance or radical treatment. Then, when I see them in the clinic, we discuss these options. We never tell people what to do. We always ask the men to think about what they would like to do, but we also give them the Cambridge prognostic group they're in. We give them the Predict Prostate estimates. And just recently, the Cancer Alliance in our region, in our network, has developed a tool that patients can go to understand about what the recommendations are. So that also gets given to them. If they then look at all of this information and they think that surveillance is right for them, they will then come back to the active surveillance clinic where I will see them. And what we do in Cambridge is we have a risk stratified surveillance program. That means to say that not everyone goes onto the same follow-up program. We are able to calculate and work from their CPG and predict whether they're likely to progress or not. And then we can tailor their follow-up based on that. And very often, many of these men, particularly the lowest risks, don't have to be seen very often. So we are able to use these tools to first counsel men for them to make decisions which are right for them. And we can also use that to work out their risks of things happening in future. And we're able to tailor the follow-up on that. But I won't expand too much into that. I can say that since we have introduced these tools in our hospital, if we compare the number of men who went on to a radical treatment versus the men who went on to surveillance, we have seen a dramatic reduction in the number of overtreatments. So for example, CPG1, which is low risk, our active surveillance uptake has gone from 76% to 95%. And for favorable intermediate risk, which is a better part of intermediate risk, or CPG2, we've been able to nearly treble the number of men going on to surveillance once we're able to explain risks and benefits better. So this is just a bit more of an example of how we risk stratify the patients, probably not so important for today's talk, but we've been able to do this using evidence and data, and actually our work has been validated in Spain and using Swedish data sets as well. So this is our stratified cancer surveillance program. Men go into one of three groups based on their CPG and also the PSA density, and we tailor their follow-ups accordingly based on that. We also have inactive surveillance, a session where we teach men how active surveillance is and what it's all about, and we have a nurse who leads that, and we take them through things I've mentioned to you today, and actually what risks it means and what surveillance means and what the chances are. And as a result of that, our adherence for surveillance is actually very high. We have very few men who come off surveillance for anxiety or reasons of concern. In fact, the opposite problem is when things change, they don't want to come off surveillance. So, but that thankfully is not so difficult to manage. As I mentioned, our rates of coming off surveillance is actually very low. The international average is about 40% of men on surveillance come off by 3.5 years for many reasons, including progression or worry or other causes, whereas our rates are actually about 15%, so 3 times less. So to summarize, Predict Prostate is really the first and only tool that will give a balanced estimate of prognosis, which is the likelihood of dying of prostate cancer versus other cause death. It is also highly validated. It's free to use for patients and clinicians, and it's actually now available in 4 other languages, including German, Portuguese, Chinese, and we are currently working on a Spanish version as well, and French as well. So we know that use of Predict Prostate changes clinicians' and patients' knowledge about how harmful or not a cancer is, and it's been able to reduce the variation in the amount of knowledge that patients are given across various sites. Because at the moment, in many places, I know that the amount of knowledge and what knowledge people are given varies greatly depending on who they see, where they are seen, and actually actually what that unit might specialize in. And we don't believe that that should be a factor when it comes to making decisions. It should be the same for everyone. We know that use of Predict Prostate increases uptake of surveillance because we've seen that happen in our practice. And really our view is that both the clinicians and the patients should understand their prognosis before they make decisions about treatments or not. Because decisional regret, feeling like wishing you hadn't had treatment is a very common thing, as I'm sure you will all be aware, but you can't undo a treatment. Now, what I would hope is that Europa Uomo will find this tool useful to disseminate to your membership and, in fact, to men in future. And I hope that that will be the case. And I'm very happy to take any questions if there might be from anyone.
Vincent, first of all, I want to thank you for. Sorry, I'm a little dark in the image. I want to thank you for the presentation. Before giving the control of the further part to Tanya Estapé, we will go as she is a psycho-oncology. She will also speak about the psychological stress on this moment of critical decision. But before going to that, I have to say that I am in active surveillance since 2017. And when I did the test with your system with the data that I had in 2017, it gave me exactly the same indication of active surveillance. So the first test was positive. The second point is that we are, I think, from the experience, we are gaining not only in active surveillance, but also in early diagnosis and in multidisciplinary treatment. The impression that we patients are getting is that now the main point is not only the technical excellence of the health specialists, but is an organization problem, management problem. We have early diagnosis, and it's still now only the community has sent out a recommendation to do early diagnosis. Many countries are not doing that. So that shows that the importance of having reliability on tools. This one is mostly for active surveillance and treatment, but all other situations or other things will help us to be more effective. So instead of working only on treatment after diagnosis, we will be able to avoid big problems and work better. So it is, I think, this tool is in this area, in the area of data information, of experience management information, which will help to be more effective. In the sense that it is easier, let me say this one, it seems easier now to treat after diagnosis. What is difficult is to do early diagnosis because of social limits, social obstacles, and it's difficult to do active surveillance because active surveillance requires more risk evaluation, requires more a more difficult attitude from the patient than just doing the treatment. And this, so your tools, I think, is good in this area because it gives this type of gives a possibility, one of the tools which goes in the direction of more and more efficiency in managing the problem, let's say. Okay, so now after having said too many things, too many words, I will leave the word maybe to Tanya, which is with me taking care of many activity in active surveillance. And then there will be a session of question and answer, and Tanya will be helpful in trying to address the questions that will come.
Okay, thank you, Cosimo, and thank you, Vincent, for reaching Europa Uomo and for explaining your tool. I am one of the board director of Europa Uomo, trying to focus some part of its activities to psychosocial aspects that are very important, especially in prostate cancer patients, because the other day I was doing a review on the last publications, last 5 years, for instance, comparing psychological issues, breast cancer or prostate, and the difference is huge. At least in Spain, for instance, until now, it has been very difficult to have data or give support to men with prostate cancer. I think that the tool is a very good option because medical decision making will be I am thinking of my country because we are not our patients are not so used to make decisions. They, especially prostate cancer, that are usually old or not very young, and they are very used to receive the decision from the doctors. But I think the future is here, and this tool will be very, very interesting and very important. And I told you, Vincent, and I want to repeat here, I only perhaps miss, and perhaps we can collaborate in having some data about the psychological aspects, because usually patients that are in groups as Europa Uomo or the one we are leading, a concrete profile of patient that is willing to know information, is informed, but there are other patients that are not so public exposed, that are more depressed or more ashamed because of their prostate situation. And we know for some studies that it is needed sometimes to reach the psychological aspects. And undoubtedly, having the tumor inside will help them to reach their fear of progression, their anxiety. And I want to reach this point because it's very important when you are deciding, when patient is deciding to put in one of the sites the psychological traits, the psychological past personality, if there is a history of psychological problems. You know that prostate cancer patients in the first year after diagnosis are the cancer patients that have a high risk of suicide. So it's not a thing that is we should do as if it wasn't here. It's very important situation. And I strongly believe that this part is very important, because I have some patients that are so anxious because they have the tumor inside. So I think that one thing we should, I was reading your summary and I say, I miss honestly miss this part, no, to implement some psychological measure, even family support, even couple support, at which point, if the patient is working, not, I mean, more, I have copied the sentence you put of a surgeon, I think a surgeon, that we should focus not in the organ, but in the person. And the person is also his quality of life, I know you have done something about quality of life, but I would like to take it here to focus to this part, for me, very, very important. For instance, in some studies, even they have erection, they have problems in sexuality because their anxiety is very high. That's an example. So I just want to take it here and then give room to people who want to make some question to Vincent, of course.
So Tanya, I completely agree with you. What we have found is that actually there are two things. Predict prostate, when I counsel patients, and I'm usually the one telling them about the bad news. And the minute they hear that they've been diagnosed with prostate cancer, you can see their anxiety sitting there in front of you, becomes very stressed. But when I start to talk to them about where they sit on the CPG scores and Predict, you can see them visibly relaxing. And I have found that quite a stunning thing. But of course, I have not measured it, not like you, you're an expert. So certainly in the counseling and the information on a new cancer diagnosis, particularly where you have got earlier diseases, it seems to have a huge impact on detoxifying what is a very anxious situation. But the other thing is actually in active surveillance, because I'm very interested not in how many men go into surveillance, but how long they stay on surveillance.
Yes.
Because a lot of people say that, oh yeah, look, our surveillance is very high, but then you find that they're dropping out very quickly. And I think that it's because if you don't have that ability to go back and look at something very objective, like the tool predictions, because we write to them with it, then you forget, very easy to forget, that actually you did have very low risk cancer and your risks were low. So when we use that and they're reinforcing it all the time on surveillance, that's actually why, and we have a very structured surveillance program, it means that the chance of coming off surveillance is very low. And I think that, so that there are two things. It's a continuous reinforcement that you do have a low risk disease, which numbers and figures and facts can do much more than just simply saying something and then, what did they say, So we find that anyway.
Okay. Thank you so much. Is there any question from the audience? We are 18, so we can simply raise the hand in the screen or say, just, I will have a question. No questions? Cosimo?
I have a question.
Okay,
It's Leopold from Vienna, Austria. Active surveillance, I suppose, is in close relationship to control of the PSA value or biopsies or other control possibilities. Is that right? Or what's going on in the period of active surveillance? You start with a PSA value biopsy, and you have a certain diagnosis, and you can estimate that the cancer is not aggressive, so you can talk of propose active surveillance, but in this period, I suppose there is a continuing control of all these values. So that can be the most simple is the PSA value, but biopsies should possibly also once a year or half a year be a tool for the control.
So this is a package, and it starts off with, first of all, estimating at the start of a journey what is likely to happen. And that is what Predict does. Predict tells you what the likelihood is for an individual to actually die of prostate cancer, which means progression. Now, if somebody decides on surveillance, how you monitor, what you use to monitor is actually a separate thing. And we are able, because we start on a very good baseline, to work out whether that individual needs a high intensity of follow-up or a low intensity of follow-up. So for example, how often you do the PSA, how often should you do a repeat MRI scan? And in fact, if you do that, if you use the models, you can actually stratify, means divide them into the groups I mentioned, and I didn't go into detail here. Very often, you don't need lots of biopsies because biopsies are invasive, they're painful, they can cause problems. So we estimate what the chances of progressing, and then we will tailor when they need a biopsy based on that. So the PSA, yes, we also use MRIs as well. But biopsies, we try not to do as much as we can, as we need to. Even then, when we stratify the groups, most of the men in these groups, in the good groups which go into surveillance, they don't really need to be seen for maybe a year, sometimes 18 months. We also ask the men to measure their PSA tests with their GP and keep a record. And we actually tell them, look out for a particular level. And they then, if it goes above that, they contact us. And Tanya mentioned something really interesting about technology and how we as people and as men are engaging with it. It is certainly true that not every man and family who comes can manage the data we are telling them. But increasingly, we are finding that because of the way we are using our phones and our iPhones and our computers and everything for engaging, it's becoming very easy for men to actually start to do a lot of this stuff, which is the reason why Predict Prostate is a free-to-use website, which can be accessed by a man anywhere. And we are also developing other tools in surveillance, which also work in the same way. So yes, absolutely monitoring. And we use a baseline to tell us when to do the monitoring. And then we empower the men to actually do their own self-monitoring.
Thank you.
Thank you. Is there any question from the audience? Take the advantage of having here this opportunity of having Vincent and his tool.
I'm Hope here.
Hello.
Hello. I mean, when I see Prostate Predict, I'm in a prostate cancer support group in Ireland, and I get contacted regularly by men who are offered options of, do you want to go on active surveillance or do you want surgery? And the men are anxious, their family are anxious. Where I see the benefit of Prostate Predict is that you could refer the men who come for information who are anxious to say, look, use this device, and this will support the information that they're getting from the urologist and will give them almost a second opinion on the quality of life issues that follow from active surveillance. And that's where I see a real benefit to patients who come away from a consultation and said, I've been offered active surveillance, should I consider it? And you're saying, look, if you feed in the key figures that your urologist have given you, it will explain in another format what your options are. And I think it'll reduce the anxiety and the comfort. And that's where I see where we're in sort of a support group, that we can refer men to this thing, and it will help them to understand what the options and the quality of life issues. And a separate thing that Vincent was talked about, which I'm on active surveillance for 13 years. And one of the issues that concerns me as a patient is you have to keep it under review. And I'm not always 100% confident of the biopsies. I'm 13 years, I've had 5 biopsies. I get my PSA every 3 months. And anytime you go back to your urologist, you're still anxious because you know you have a cancer and it may develop and you have to keep an eye on it. So that is an area that as a patient, I'm more anxious about. But unfortunately, I suppose, when you're approached with the first diagnosis, you know very little. And as you go through it, you'll learn a lot. But I want to thank Vincent for developing this tool that I think it's a great opportunity. And I think the groups that are in supporting men, I think we should direct them and I get them to use it because I think it's a great opportunity to reduce the anxiety associated with diagnosis.
Tom, thank you for that. You absolutely hit the nail on the head, actually. That's exactly what we intended for this to be done, is so that, you know, men can get, if you like, this second opinion or at least independent assessment. So I'll be very pleased to hear that. And I'm trying to reach out to Irish urologists, actually, to try to disseminate this to our neighbors. So we'll see if that's successful.
Thank you. Is there any other question? More men that want to ask something to Vincent? No questions? No?
Okay, I can ask, Daniel.
Okay, thank you.
Active surveillance is very important for getting on with screening, as we talking about whole Europe and the Nordic land too. So if we can make a very good job in active surveillance, it's much more easy to start with organized prostata testing or testing. The problem today is that it would be a lot of testing or also a lot of active surveillance and tell the patient what is important for them. Because if they start testing and screening men in the 50s, between 50 years and 60, I would say that 50% of them have if you see it in the microscope, they have a prostate cancer. So it's a big job for healthcare and take care of all these prostate cancer patients. And if the test with the risk calculator, TSR risk calculator and Amber is good enough, it should be good enough for select people who go to active surveillance, and the other one goes to radical surgery. Or today we have the high risk, they go to radical, and the low risk go to active surveillance. We also have intermediate group, 3+4 and 4+3 Gleason, and this group have been a big problem because what shall we do? Shall we go to active surveillance or shall we take a radical treatment? But today there is new markers, something called cribriform, and something new marker with RNA. So they're selecting to the people who goes to active surveillance and they to go to radical treatment is much easier today. And but we need doctors who have time enough to tell them that is important, and have a very good protocol, so then can have confidence to the treatment. And but what's happened sometimes is that on small local hospital, sometimes or they forgot calling in for a new PSA taking and MRI, and that's not good. Therefore, we in Norway we want to have the radical treatment only and the active surveillance on the big hospital. So I hope we got very good protocol for active surveillance, so we can go for screening and organized testing. Thank you.
I think you raised a very important point. You see, the thing is, the reason why prostate cancer screening never took off and actually never happened despite the ERSBC is because there was significant amounts of overtreatment, and the survival benefit from screening was actually quite small. So if you go into PSA testing or screening without a really good plan for how to deal with all the cancers you're going to diagnose, you will create a big, major public health disaster. And to be frank with you, we don't really need any more markers or tests. If you look at Predict effectively does that without any costs. And a lot of men in intermediate risk actually go on to surveillance when they see their risks are actually not that high. The reason for developing Predict was actually to deal with this, because you need to have confidence in the decisions you're making. And also, most of the clinicians have their own views on things which are not actually informed by best data. So you have a lot of overtreatment, a lot of men, particularly intermediate risk, going to have radical treatment. It's going to get worse if you do more PSA testing. So in my view, we need to make sure that we have things like Predict, which can empower patients to make that decision. Otherwise, you're going to have a lot more men having treatments they never really needed or benefited. Now, once you're on surveillance, the confidence in surveillance and how it's done is, you're absolutely correct, is actually crucial. And like I said to Tanya, we have to have those robust structures. What I have found, and what we have done in Cambridge, is we realized that the most important person to make sure that the surveillance is working is the patient, not the doctors, not the hospital, not the nurses, because they can't cope. So what we need to do, just like we Predict, is to empower men to actually have the data and access to validated tools and monitoring systems, which they can actually self-manage. And like I said, we've done that, some of that in Cambridge already, and we've been very impressed by how men engage with it and actually have confidence in it.
Okay, thank you.
I think there is some question in the chat. Do you provide some kind of information on patient journey?
Yeah, Imri, is it? Hi, I'm not quite sure what you mean. What do you mean by that?
I mean, some kind of information that you tell patients that, okay, now you go to active surveillance, and later, if that happens, then you will be treated like that. And if other things happens, you will be treated another way. And so this, all these possibilities. And so I'm not just people who are taking active surveillance.
Okay, so we don't have a plan which is laid out for years, but what we do have is multiple sources of information. So first of all, it starts with the counseling, like I mentioned. We'll talk to them about their risk and their estimates, and we actually give them in a letter their predicted survival benefit from treatment or not. So they get that. If they decide on surveillance, we discuss how the surveillance will work for them. we invite them to the surveillance seminar, which I mentioned to you, and we have a patient information leaflet which explains how the surveillance works as well. And then we arranged a follow-up for them based on their risk that we would calculate of progression over the next 3 years. So, and then we arrange the follow-ups. And then the most important thing is we tell them to do their PSAs and actually tell them what to look out for. So it is very much a two-way process that we do. When and if there is a change, so for example, if a repeat biopsy shows a change in the grade or the type of prostate cancer, or the MRI shows something is growing, we talk again and we reassess the risk again and actually discuss, well, does this mean that you need to have treatment? Or does this mean that actually the cancer has grown a bit, but actually you are also older and the change is not very much? Because I think there is a basic misunderstanding about surveillance and prostate cancer, and that is that we expect that this prostate cancer will not change. But the fact is, it is going to change because it is a cancer. But that does not necessarily mean that the prostate cancer is going to affect a person in their natural lifetime. Other things will come into it. So it is always a dynamic discussion. And I think one of the other big problems for a lot of clinicians is the minute anything changes, they think someone should have treatment. But that is actually not evidence-based. As we know, when we do predict calculations for people who have a bit higher features, yes, they have a slightly higher gain from treatment, but usually the men are older by then. So there's always context. For example, if you have got a grade group 3, 4+3, in a man who's 80 years old, as opposed to a man who's 50 years old, the survival benefit is hugely different. So, you know, the counseling is also hugely different. You cannot sort of use one thing in its own isolation and make a plan out of it. I think you're on mute, Tanya.
Okay, thank you. True. Is there any other question to Vincent? I've had some interesting questions. One more. Another question? That's an hour, so I think we can leave Vincent if there are no more questions. Thank you so much to spend some time explaining us the interesting tool that undoubtedly will help or is helping a lot of patients, assisting them to decide between different options. And Anya is saying you that the recording of this video and a typed script in Word will be available on the Europa Uomo website in a few weeks. So if somebody has lost or want to recall it again, you will have the option of do so. Thank you and have a nice afternoon and night.
Thank you, Cosimo. Thank you, Tanya. Thank you, everyone.